Very good evening to one and all. Chaturmukha Samarambham, Vagbhadacharya Madhyamam, Asmadacharya Paryantam, Vande Guru Paramparam. Ragadi Satadana Shaktana, Sheshakaya Prasadana Shesha, Autsukya Moharatitan Jagana, you Apurva Vaidya Namustu Tasmai. Invoking the blessings of all Acharyas of Ayurveda, once again we all are here for another episode of Acharya Rasayana. Respected Ramanathan sir, Dr. Srijit, Dr. Rahul, and all our dear participants. So we are here into the 131st episode of Acharya Rasayanam. Directly onto the session. Today we have a very well-known face of Ayurveda, Dr. Murlidhar Sharma sir, a great teacher to his students. He had been with us even before on the 39th episode of Acharya Rasayanam, sharing his clinical experiences on coronary artery disease and hypertension in the August month of 2021. Once again, on the 131st episode of Acharya Rasayanam in 2023, we are blessed to have Murli sir again with us to share his expertise on the topic thyroid disorders. And as we all are aware that the incidence of these issues are rising in our society, and people who are approaching Ayurvedic practitioners as first line of therapy is also increasing, who are coming to us with fed up with the increased dose of Thyronorm or Eltrosin is also increasing. So multiple levels of clinical presentation and multiple level of dealings need to be there. For that, I'm sure eminent clinician like Murli sir can guide us, the young practitioners and people all over India who are practicing these things. I mean, especially thyroid disorders. So, behalf of all of us over here, with all respect and humility, I welcome Murlidhar Sharma sir for the session. Sir, please. Namaste.
Okay, thank you. I hope I am audible.
Yes, sir. You are audible, sir.
Can we start the presentation?
Sure. Yes, sir. Yes, sir. Direct.
Namaste, sir. I'm Dr. Ramanathan here.
Namaste, namaste.
Namaste.
Okay. I hope the screen is visible.
Yes, sir. Screen is visible, sir.
Okay. So, thank you for the opportunity given to me to share my experiences, views with the experts here. Now, the topic given is about thyroid diseases and Ayurvedic practice. And one of the important issue is Ayurvedic literature. If you look into the Samhitas have very little description about the thyroid as such, except for the Galaganda Roga, where the Galaganda can be located to the thyroid diseases. The description is very less. Whereas, from the current physiology point of view, thyroid is one of the important hormonal entity which is absolutely necessary for the maintenance of the normal functioning of the body. I will not go into much of the physiology and theory part, I will directly go into the practical aspects. But certain basic issues which you have to know, the most important part of that thyroid secretion, thyroxine secretion in the body is regulated at multiple levels. The first of the thing is the thyrotropic hormone, which is secreted by the pituitary, would be stimulating the thyroid to release the thyroxine, which is already synthesized. Thyroxine is synthesized from phenylalanine and it's stored in the thyroid follicles. And whenever there is a stimulation from the thyroid through the thyroid stimulating hormone, the thyroxine is secreted in the form either T3, triiodothyronine or tetraiodothyronine. Or there is another reason, the reverse T3, which is now being known, which will also have its pharmacological action. For this, you need a raw material of the iodine, whereas phenylalanine is already present in the body in the form of an essential amino acid. And the thyroxine, which is released from the thyroid gland, will reach to the target area through thyroglobulin. So, thyroglobulin is one of the essential protein which is necessary to carry iodine into the thyroid gland, as well as it is also necessary to keep the thyroxine activity over the body. The issue of the release of thyroxine from thyrotropic hormone from the pituitary is based upon the requirement of the body. Now, the functions of the thyroxine, I will directly jump into the issue. The functions of the thyroxine are from the embryological life. It's essential for the development of the fetal organs, particularly fetal brain development, as well as the maturation of the skeleton. In the adults too, it has a basic metabolic rate, the whole metabolic activity. Metabolic activity is the production of the energy is regulated by the thyroxine, and whenever we study the functions of the thyroxine, one of the important means of studying thyroxine is assessing the basal metabolic rate. That's about the oxygen consumed per unit time of the body. That gives a indirect expression of the thyroid activity of the body, and it increases the effect on the heart. It stimulates the heart to pump more, and the rate of contraction also, the ability of the heart muscles to conduct the electricity also is enhanced. That's the inotropic action, as well as the strength of the muscle action also will be enhanced. So cardiac pumping activity will be enhanced. It increases the sensitivity to catecholamines in the heart muscle. So directly it stimulates the heart to produce more activity, as well as indirectly through the catecholamines too, the heart activity would be enhanced. So the peripheral blood supply would be enhanced, tissues would have a better nutrition under the effect of the thyroxine, and it also increases the motility of the intestines, and it enhances the functions of the intestines too. It enhances the turnover of the calcium in the bone. The calcium in the bone is not a static one. There is always an exchange of the calcium from the soluble to insoluble form in regular physiological conditions, and this rate is enhanced. It enhances the glucose level in the blood, and ultimately it's absolutely necessary for the production of the energy and sustenance of the physiological activities. It enhances the stress capability to resist the stress. Stress tolerance is also enhanced by the activity of the thyroid, and it decreases the serum cholesterol. It also enhances the conversion of carotene to vitamin A, and the maintenance of the heat of the body, the thermal regulation also is a major function of the thyroxine. Now, if you compare these functions with whatever we see in Ayurvedic literature, these functions almost are carried by the what we call as Dhattvagni. Dhattvagni, of course, among the Agni, the different varieties of the Agni, we have the Kostagni, then the Panchamahabhutagni, the Dhattvagni. And very interestingly, the description about the functions of the Dhattvagni are very few in Ayurvedic literature. But if you look at the functions of the Dhattvagni functions are Tatra Ahara Rasaha, Vyanavikshiptaha, Yatha Swam Saptatu Dhattvagnisha Prama Pachyamanaha, Swa Atma Prabhava Pratyuti Samanantaram Eva, Prapta Raktadi Dhatu Sandaka, Kalavadu अस्खलित बल प्रमाणो देहम ऊर्जयित्वा धातुं धातुमलांश्च पुष्णोति. The whatever we see on the right side as the functions of the thyroxine, the same are summarized in the form of deham ujjayitva dhatun dhatumalamshcha pushnati. So I would consider the functions of the thyroxine hormone or the functions of the thyroid gland as the Dhattvagni. The same in Charaka is mentioned more specifically, or rather it's almost the same issue, but the description of Charaka Samhita would be Vividham, Ashitam, Pitam, Didham, Khatitam, Jantohitam, Antaratmi Sandakshita Balena, Yathasvena Ushmana Samyak Vipatyamanam, Kalabata Anamastita, Sarvadhatu Patam, Anupahata, Sarvadhatu Ushma Martha Tejasa, Dhatu Ushma Martha Srotaha, Kevalam Shariram Upachaya Balavarana Sukhaisha Yojayati, Sharira Dhatum Urjayati. Now, these are the functions of the Dhattvagni. Again, they are exactly the same as that of the functions of the thyroxine hormone as such. So, I would just equate, rather, I would look the functions of the Dhattvagni as what we see in case of the thyroid functions as such, exercise of the thyroxine functions, and this helps you to plan the management in case of the thyroid disorders. Now, coming to the practical issue of thyroxine, because as I told you, the details about the thyroid hormone and thyroid gland or the whole mechanism of endocrinology available in the Ayurvedic text is somewhat lesser. We have to depend upon whatever the tools we have, and based upon that, I will just directly jump into the topic of clinical practice than going into the theory. The assessment of a thyroid function would be based upon what we popularly call as the thyroid function test. And the most common, I stress upon that word, the most common thyroid function tests are the thyroid stimulating hormone assay, T4 or thyroxine 4, that's the tetrahydrothioronine assessment, which is the normal ranges are described as the thyroid stimulating hormone. The normal ranges are 0.3 to 4.0 micro units in per liter or milliliter, and free hormone again nanograms, it's in the form of nanograms, 0.7 to 2.1 nanogram per 100 ml, and the free T3 is 1.4 to 4.4 pg per dl, that's 100 milliliter. Then these are the most common thyroid function tests: TSH, T4, T3. And then in addition to that, in specific conditions, you may go for antithyroid antibodies, either peroxidase or simply antibody assessment, or nuclear scintigraphy for the imaging, FNAC of a nodule localized condition. These are the common thyroid function tests which we do. Now, the issue is the thyroxine hormone is presented in form of two forms, the T3 and the T4. T3 is the real more potent thyroxine hormone. So whenever it comes to the question of normal functioning of the thyroid gland, and when we decide like whether the thyroid function is normal or not, we depend upon the ultimate final, rather to a great extent, the functions of the T3. We give more importance to the levels of the T3 than levels of the T4 in majority of the disease conditions. Of course, there are certain conditions where T4 also is important, but in the short duration, like see, whenever the body needs to react to a stress immediately, in that situation, T3 level is enhanced, whereas T4 level would be constant. But if at all you have to have a long-term this modification of the body functions, then T4 level is enhanced. Like, to give more simple example, suppose if there is a situation where you are exposed to the extreme cold and your body temperature has to be raised immediately. Suddenly you have been put into a chamber where the temperature is very low and your body has to produce more heat. Then at that moment, the T3 level will be enhanced. The body would have that kind of a mechanism where the T3 level will be enhanced so that the body will produce more heat and it will compensate with that immediate fall in the temperature in the surroundings. Whereas when the temperature is gradually reduced during the season, like in winter season, when you change over from one season to the next season, from summer to the winter season, where the temperature is gradually reduced, to meet with that kind of a change, more of T4 is secreted. So the whole activity, the balance between the T3 and T4 is maintained in such a way that the body can react to a stress in short duration or a stress in long duration based upon the requirement. A short duration stress could be like an acute disease. A long duration stress would be a chronic disease of the same form. So T3-4 levels and the ratio of the T3-T4 can alter according to the basic requirements of the body, and this fact has to be kept in mind when we interpret the results of the T3-T4. Now, thyroid functions, thyroid hormone levels also are not constantly seen in the body. It can vary according to the levels of the physiological activity of the body as well as the time of the day, diurnal changes. Now, as we discuss about the dosha sthiti, the situation of the dosha, as per the diurnal conditions, like in the morning you have kapha and in the evening these vayohorati bhuktanam te antamadhyadigaha kramat. Similarly, the level of the thyroxine, also the thyroid stimulating hormone as well as the free thyroid T3 also would be changing in the body based upon the rhythm of the activity. Like in the daytime, during the daytime level, the TSH level would be gradually raised, and as the TSH level is raised, you will have more of the thyroxine hormone. The T3 hormone also would be more at night time. It gradually reduces at the end of the day and then it gets raised at the night time. So the level is not constant throughout. The TSH level is represented by the black line and the free T3 level is represented by the red line, a standard model of the changes in the circadian rhythm or the day-wise rhythm starting from 9 o'clock in the morning to 9 in the night. The changes, 9 in the next day from 9 a.m. to 9 a.m., 24 hours. It reduces, like gradually it starts in the early morning, it will be moderate to high. In the middle of the day, the thyroid stimulating hormone levels reduces, as well as the T3 level reduces. Then gradually it peaks up. At midnight again it peaks up. This is the average trend. Of course, this circadian rhythm can change according to the occupation, according to that particular day's activity, the stress and so on. Now, the whole point why my stress upon these issues is whenever we depend upon the T3, T4 results and look at the lab reports, many times you will be overawed or may be confused about the interpretation. Now, there is no need of having that confusion because none of the hormone levels in the body, it's not only about the thyroxine, none of the hormone levels in the body would have a static uniform level. They will always change according to the stress or maybe the need of physiological need of the body, and particularly the thyroid, particularly and T3 as well as the TSH would have a significant change within a short duration. The TSH also varies as by the day and night, the same issue which I have shown in the previous graph. It can change with the certain pulsating activity, like it's not uniform, and it can reach the peak at night, and in the daytime it tends to be comparatively lower. This is the usual range, but when I say day and night, it depends upon the average physiological activity of the person, who would be more active during the day and less active in the night. Suppose the same is reversed based upon your lifestyle. Those who tend to be more active at night and less active at day, the rhythm can change, and this change in the rhythm also can produce some changes in the physiological functions of the body. So that comparison of the diurnal changes, the circadian changes of the doshas, Vayoho Ratrimittanam Tayanta Madhyalika Krama, those are very much relevant in case of the functions or levels of the thyroxine hormone also. The thyroxine hormone, particularly TSH. Now, I stress upon the TSH level because the next topic which I am going to deal with would be about the same subclinical hypothyroidism, where the TSH is one of the criteria. The levels of the TSH also would be changing according to the age as well as according to the season. As we discussed about that, the average, now whatever we have put in this screen, is the average from a large number of population, need not be exactly the same. In the summer, the TSH level would be 2.16, whereas in the monsoon, it will be 1.71, quite low. And in winter, it's still high, 2.97. So, depending upon the environmental factors, the levels can change. The same is true with the T3, T4 also. And it also increases as per the age. At the age of 80, the old age, the TSH level tends to increase much more because the thyroid stimulating hormone is the one which makes the thyroxine release the thyroxine, makes the thyroid gland to release the thyroxine. If the thyroid gland is healthy, it needs lesser stimulation. When the thyroid gland is not equally healthy or equally energetic, the amount of the stimulus required would be more. So when the thyroid gland is less active, the level of the TSH increases. And so whenever the TSH level increases, it suggests that the thyroid gland requires more stimulus. It needs to be pushed more to produce the normal activity. Now, coming to the issue of when to decide as hypothyroidism and so on. Now, from the clinical point of view, we use the word hypothyroidism when the serum TSH and T3 levels are altered, and they are classified as a primary hypothyroidism where the free T4 level is less than normal and the TSH level is raised, and when it is called as subclinical where the TSH level is normal and TSH level is raised and free T4 is normal, and that if the TSH level is reduced and free T4 also is reduced, that suggests a central hypothyroidism where primarily the tissue, the pathology is somewhere beyond thyroid. Either it could be in the pituitary, or it could be some other illness in the body, or it could be due to the effect of the drugs. So, from the clinical point of view, when we make the diagnosis of a hypothyroidism, it's based upon the pathology of the thyroid gland, you'll primarily have two groups of situation. One where TSH level is raised and T4 and T3 level also could be reduced, which is what we call as a primary hypothyroidism, where the patient would have all the clinical symptoms of hypothyroidism. But there is another important group that TSH level is moderately raised and the T3, T4 levels are normal, and this is called as a subclinical hypothyroidism. Now, when I discuss about the disease of the thyroid, I would start with the subclinical hypothyroidism as the first topic, because that's one of the most important area of real confusion and concern, and an area where we can produce a real change in the outcome, and the total myths about the disease can be just clarified or maybe just modified. Because the issue of subclinical hypothyroidism is a real burning issue now. It is said that now more than 5% of the total population around 15% of the total population in the world are now diagnosed as subclinical hypothyroid, and they are treated with the thyroxine supplement. This is what we get the data from the global situation. But if you look at the patients in our condition, in India, very interestingly, the present generation of endocrinologists, they often say that even if there is a mild change in the TSH, that patient needs a supplement with the thyroxine. And what we see in the clinical practice is almost every third patient who comes to you after the middle age would be having thyroxine supplement, maybe at a low dose or a high dose, and virtually the patient would never have that clinical signs of hypothyroidism. They never had that clinical symptoms of hypothyroidism, and they are diagnosed as subclinical hypothyroidism based upon only the raised TSH level. Now, this is one of the area where from a clear picture or a correct interpretation can produce a change in the total clinical outcome and reduce the burden of the disease, reduce many of the complications. From that point of view, I would stress upon these issues which are well known but often neglected by the practitioners. Contemporary practitioners, of course, a standard guideline practice, if you follow, that kind of error doesn't occur. But what we see now is a so-called modern practitioners who criticize Ayurveda very energetically whenever there is any opportunity. They would never miss any opportunity to criticize Ayurveda and Ayurvedic approach. What the practice they do is something which is rather something beyond that standard practices, guideline practices, and that makes a large number of people come for Ayurvedic treatment. So from that point of view, I give more importance to a subclinical hypothyroidism than any other established thyroid diseases. So, whole order of presentation would be something different from what's generally expected. Generally expected would be whenever you discuss about thyroid disease, you would be discussing about a clinical hypo or hyperthyroidism and then go into the subclinical. But I would go in the reverse manner because it's the real burning problem in the clinical practice as such. Now, a person having a subclinical hypothyroidism is obviously having a absolutely euthyroid state, where euthyroid in the sense his thyroid functions would be normal and the T3, T4 level would be normal. And the same can continue for about a stage up to around. Now, these are all the average standard data which are collected from standard peer-reviewed journals. So these data are not mine. I put up again stress upon that part. I am not creating the data. But the basic issue is more than 60% of the cases, they would remain normal thyroid. They would not have any thyroid symptoms for more than 5 years, depending upon the TSH level concentration, and even without any of the antithyroid antibody levels as such, and they may remain normal for quite a long time. Only about 1 to 5% of the cases per year, they may go into the next stage of overt hypothyroidism, where the patient would have a clinical signs of hypothyroidism. Now, these 1 to 5% of the patients who go into the stage of hypothyroidism only require supplementation with the thyroxine, whereas the others, where the TSH level may be raised moderately, they may not require the supplementing with the thyroxine as such. The standard guideline of subclinical hypothyroidism given by the universal guideline, maybe that it's by the Thyroid Association of the USA as well as the WHO sponsored guideline, is if the patient has a elevated thyroid stimulating hormone and the normal thyroxine function, the guideline says the patient doesn't require the immediate treatment. You assess the TSH levels and wait for 8 to 12 weeks and see if the functions are, if the patient has a thyroid antibody, TPO antibody or not. Even if the patient has a TPO antibody negative, then you do not have to give him treatment, just monitor if the patient develops symptomatic or not. If the TPO level is raised, you check the thyroid function level annually. Again, even if it is positive, don't have to treat. This is a standard guideline given. Now, if the TSH remains continuously elevated, doesn't subside after a few months of period, even then, if the patient doesn't have a hypothyroidism symptoms, then during the follow-up, if the TSH level is more than 10 nanounits, then only, and even in that 10 nanounits, if it is less than 10 nanounits, then there too, if the normal level of T3 is normal, no treatment is recommended. Instead, it has to be followed up, and you can consider 6 months, maybe occasionally, a 6-month trial of treatment is required, may be suggested. That's suggested. No treatment is recommended. That's the important point. Now, if the TSH level has become lesser or equal to 7 or maybe less than 7, and that TSH level is at 10 units level, then consider 6-month trial of treatment, and particularly if the age is above 70 years, and if the patient is having cardiac risk factors and TPO as well, there are no cardiac risk factors, then only you have to treat the patient with the thyroxine. Now, if the TSH level is more than 10 units and again normal T4 levels, and if the age is less than 70, then only a treatment, recommended treatment, especially if cardiac risk factor or TPO is absent, these antibodies are positive. If the antibodies are positive, then only the treatment of thyroxine is needed. If the age is above 70, then consider 6-month treatment trial, especially if low normal as such. Now, if the patient has a frank symptoms of hypothyroidism, of course, the patient needs treatment with the thyroxine. Now, if you look at the spectrum of the patients who have raised TSH levels in the current situation, if you refer a patient for particularly younger age females, if you refer the patients for the thyroid function studies, almost every third patient would have a raised TSH level and the T3, T4 levels would be normal. And if the patient goes to a contemporary endocrinologist, essentially the patient will be prescribed with the thyroxine hormone, and that's the real situation which we are facing. And every patient, almost every third patient coming to Ayurvedic clinics for some or other management would have a thyroxine as a prescription, and majority of them, more than 80% of them, they would be in that category where the standard guideline doesn't suggest about the thyroxine prescription. Only about 20% of them, they may require the thyroxine prescription as such. Now that gives a scope for the management from our point of view. And when a patient comes to me with this thyroxine levels, TSH levels raised, I would be just looking at those issues, and if the level is, TSH level is more than 10, and if the T3, T4 level is reduced, only in that condition, I would allow the patient to continue the thyroxine hormone. Otherwise, I would be always attempting to or preferring to discontinue the thyroxine hormone. But thyroxine hormone again cannot be discontinued all of a sudden. Another important factor which makes the TSH level raised and the thyroxine level in the body could be affected could be due to the other drugs. Now, majority of the patients who are having prescription of some other drugs for other reasons, there again, though the patient may have a normal thyroid functioning, they may be having these effects of the hypothyroidism signs like subclinical or clinical hypothyroidism due to the drugs. And the most important drugs which can produce these changes are iron, calcium. Now, again, one of the common prescription which you see with the patients coming to us, almost about more than 70% of the patients in the older age, particularly females, would be consuming calcium essentially. And iron also is supplemented quite frequently as a tonic. Zinc now has become a craze as immunity builder, and hence you will have many of the patients who have these prescriptions. Of course, the other drugs, they may not be so common, like aluminum and cimetidine, of course, is one of the commonly used drugs as antacid or in the gastric irritation conditions. Caffeine is one thing which can reduce the thyroid level, and TSH level could be raised. Now, these are the drugs which can be definitely stopped or modified, by which the need for thyroxine supplementation can be definitely reduced and prevented. So, a careful assessment of the medical history of the patient and identification of the prescriptions given to the patient earlier and the patients using those medicines, that can help the patient a lot. And you will have good number of patients who have altered TSH levels simply because of calcium, iron, or maybe the other drugs which are not necessary. Whereas certain other drugs like phenytoin, carbamazepine, phenobarbital, rifampicin, which are essential drugs which cannot be stopped. Fine, in that condition, there could be a reduced T3 level also, and in such a patient, if there is a situation of where the thyroxine is prescribed, I would not just modify that, because these drugs, modification of these drugs would be difficult, because the basic disease condition requires prolonged treatment. Like epilepsy, where phenytoin and carbamazepine is prescribed, you cannot just modify the dose immediately, or you cannot stop that. So that also has to be one thing which you have to keep in mind. In that condition, fine, a supplementing the thyroxine necessary, it may be necessary, even if the patient may have a subclinical condition where the patient may not have any symptoms of hypothyroidism. If the patient has a estrogen hormone replacement therapy, then too there could be a level of thyroxine level reduced, but whether that can be stopped or not, that depends depends upon the patient's condition, whether it can be stopped or not. Then there is another group of drugs, of course this is not relevant in this situation. Whenever a patient is on thyroxine, if the patient is prescribed warfarin or amitriptyline, which is also a antidepressant drug, or propranolol drugs, their effect could be modified. But of course, co-prescription of these drugs have to be done carefully, but not relevant in this context. But if a patient has a subclinical hypothyroidism, and the patient, when I say subclinical hypothyroidism, TSH level is raised, the primary line of treatment would be diet and exercise. One of the important component of the diet is all that junk food. The very popular form of the food now is that pizza and so on, that junk food, which has become a craze of the day, and people always long for such substances, such food substances, and very unfortunately, now I can see the advertisements. Earlier, the advertisements would be like hotels advertising would be like you will have homely food. But now, very recent I have seen some advertisement where you will have a hotel-like food at home as advertised as their property, and this kind of a situation where the total food has been changed and the food style has been changed. Exercise has been almost reduced. For everything you need a machine. For movement, any movement you need a vehicle, or without vehicle you will never move. Such of the condition has really resulted in a increased TSH level, where otherwise there is no abnormality. It's only that your thyroid gland requires more push. It has become dormant, it has become inactive as the body has become inactive. So the activity of the body and the diet. These are the important things. Virtually, there is no need of medicine. Pranayama is another game changer. In such conditions, a regular practice of pranayama is a game changer. Generally, I don't prescribe any medicine, but if at all, now, if you do not prescribe any medicine, continuing the Ayurvedic practice would be practically not possible. So, you would have to prescribe the medicine, and in such conditions, my prescription would be Arogya Vardhini and Kumar Yasava as a Dhatvagni potion. To enhance the Dhatvagni, I would prescribe Arogya Vardhini Kumar Yasava. I am not very rigid about the duration of the treatment. I am not very rigid about the total course of the treatment. But this is given as a solace to the patient because without prescribing medicine, you may not be able to satisfy the patient. Now, about the yoga and thyroid, it's not that, as I said, I consider yoga and maybe pranayama as a game changer in the situations of subclinical thyroid gland. It's not only my view. Lots of researches are being done and lots of globally published peer-reviewed journals. You'll have lots of publication, and if you refer I have given you a few of the references. Those who are interested, they can go through the references where more detailed study about this yoga and effect on thyroid disorders are studied. And one of the very useful article is this one, a review article which is already linked in Ayush Ministry's website, where about 40 global publications are reviewed, and it's a very excellent source of information about all that structure, studies and observations, results about the yoga and the thyroid. Those who are interested, they may go through this. Discussing about this would be beyond the purview of our discussion in 1 hour. So I'll just keep that part, refer to some of those important, very useful publications. Those who are interested, they may go through these publications. Now, the other view of this is, as I told you, over-prescription of the thyroxine. Now, it's not that only me who says that the thyroxine is over-prescribed. Lots of publications are coming up. Misuse of the this thyroxine is a subject which is discussed in the contemporary science. It's not, as an Ayurvedic person, I am criticizing the modern system. It's not that way. This debate is present even among the endocrinologists. A large number of group of endocrinologists would say that the thyroxine is being overprescribed and that habits have been changed. Whereas, of course, there is another group of endocrinologists who say that even a mild modification or mild change in the TSH level requires thyroxine. Otherwise, the patient would have a cardiac complications in due course of time. But if you look at the data otherwise, if you look at the total environment of the research and the recent publications, lots of such research articles are published where the prescription of thyroxine in subclinical hypothyroidism is questioned, and even the guideline of 10 units as the criteria for prescription of the thyroxine hormone also is being questioned, and the complications of this cardiac pathology also is questioned, and these data are published. So again, those who are interested in these data, they can go through these reference articles, again all peer-reviewed journal articles. If this just a reference, again going into the details would be beyond the purview of our 1 hour's discussion. So I am just giving you the guidelines of reference. Now, what happens if you do this over prescription of thyroid, that over treatment signs? Again, a large number of patients who are being prescribed with the thyroxine unnecessarily, they would have these symptoms, and quite frequently, and these are the very common clinical symptoms of patient who comes to Ayurvedic practice, like a nervousness and a chest pain or a shortness of breath without ECG changes. No ECG changes, no signs of ischemia. Patient would have a big chest pain and shortness of breath, or a patient may have a palpitation. Again, when I say palpitation, it may not be obviously irregular heartbeat, or at times it could be audible, that or maybe as a sign, but most of the times the patient feels that the patient's heart is beating rapidly or irregularly and so on. Sweating, excessive sweating, change in the appetite, weight loss, change in the menstrual periods, again very common symptoms like patients having abnormal menstrual cycles, irregular menstrual cycles, or increased flow of menstruation during menstruation, tremors or weakness in the leg muscles, spasm of the muscles, intolerance to the heat, bone density being reduced, and vomiting, diarrhea, etc. These very common vague symptoms which do not make a diagnosis. When the patient comes to you, and we often consider this as something neurotic condition. Many times we end up with the diagnosis of neurosis. Primarily, it may not be due to the neurosis. It could be due to the over-prescribed thyroxine. If you look into the medical history, and if the patient is on thyroxine, either reducing the dose of thyroxine or stopping the dose of thyroxine can help such patients significantly. That's the important point. Now, when I say stopping the dose of thyroxine, it should not be done immediately, because if the patient is on thyroxine, whether it was prescribed with the necessity or without necessity, none of the hormones, it's not only about thyroxine, none of the hormones should be stopped abruptly, because once you administer any hormone, the negative feedback mechanism of the body would be stimulated, and the basic physiological secretion of that particular gland would be reduced, and hence whenever a hormone has to be borne off or stopped, hormone therapy has to be stopped, you need to taper that. Now this again is what we see as a prescription, this picture. If a person is on 125 microgram dose of thyroxine, by about 1 year the level would be peaked, but primarily basic endocrine secretion, physiological endocrine secretion will be drastically reduced. In such a condition, if you abruptly stop the thyroxine, there would be no thyroxine from the outside, and the endocrine secretion, the real physiological endocrine secretion would be low, and hence the patient would have a crisis, thyroid crisis, though not established crisis situation. Patient may develop very unacceptable clinical symptoms of hypothyroidism suddenly, and hence even if a patient, you decide that the patient doesn't require thyroxine and there is a over prescription of the thyroxine or a wrong prescription of the thyroxine, you are not supposed to stop that thyroxine abruptly. If the patient has taken thyroxine hormone for more than a month, if it is only a few days, 1 or 2 weeks, then no problem, it can be stopped. But if it is more than a month, even if it is otherwise, the dose has to be tapered, one of the important precautions. Now, because I am just saying that the thyroxine is over prescribed and it can be stopped. But when I say this, this important issue has to be kept in mind. If the patient is on thyroxine supplementation for more than a month or so, the dose has to be gradually tapered. You reduce the dose to half, and if the patient is taking thyroxine for a longer duration and the dose is higher, the time needed for the tapering also will be longer, and it has to be more careful. Shorter the duration of the treatment taken, the tapering duration could be reduced. But throughout during the tapering, you have to monitor the patient for the signs of hypothyroidism, and if the patient develops signs of hypothyroidism, your tapering schedule has to be slowed down or buffered. That's the important thing, and this caution has to be kept in mind. And during this, of course, supplementing with the Arogyavardhini and Kumaryasa can help a lot in reducing those symptoms as such. Now, in summary, what the WHO says is for more to 4 to 20% of the adults are having subclinical hypothyroidism, and with the thyroid autoimmunity as such, many of the patients may have that. Subclinical hypothyroidism can progress over to hypothyroidism, especially if the patient has anti-thyroid antibodies. So if there is a patient of subclinical hypothyroidism, if you see the thyroid antibodies, anti-thyroid antibodies are studied, then that patient may have a complication of a overt hypothyroidism in due course of time. If the patient doesn't have that, then there is no issue as such. Some studies have suggested that thyroxine supplement therapy is beneficial, but others have not. Now, this is exactly the point which I have discussed. This is from the standard guideline from Cleveland Clinic as such, where the same issue is discussed. So, all that purpose of my repeating this issue is, don't consider that I am saying on my own. This is a fact which is established and which is being discussed, and it's one of the issue of important debate in the contemporary science. But unfortunately, most of the practitioners in surrounding area around us, they are not practicing it, and that is a practical clinical problem. Now, that's about the subclinical hypothyroidism, one of the major issues in the clinical practice. Now, the next part is about the hypothyroidism, real clinical or primary hypothyroidism as such. Now, when a patient comes to us with maybe suspicious clinical symptoms of hypo or hyperthyroidism, to decide whether the patient has to be considered as hypothyroid or hyperthyroid or euthyroid, the current generation of endocrinologists, they are dependent only on the biochemical studies, the T3 TSH levels, T4 levels seen in the laboratory. But as I have discussed in the beginning, the T3 T4 levels can increase or reduce due to multiple factors, seasonal factors, the stress as such. So multiple factors can produce these, and they are never constant, and hence unless the levels are too high or too low, it may not be possible to make out whether the patient really has a hypothyroidism or hyperthyroidism in the based upon the biochemical parameters. Biochemical parameters, when I am not reducing the importance of the biochemical parameters, I am just saying about the limitations. There is a possibility of either missing or overdiagnosing if you depend only on the biochemical parameters and stick to those standard reference points which are given in the your laboratory reference points, reference charts. A better means of assessing this is the Wayne's clinical index. It is a very interesting issue. Wayne's clinical index was one of the important parts of the chapter on thyroid disease in the older editions of the surgical textbooks. When we were studying earlier in 80s, we were studying Wayne's index very accurately, and we were practicing it on the patients. But the latest editions of the surgical text, modern surgical textbooks, they do not have the chapter, this paragraph on the Wayne's clinical index. They have removed that, and the stress is to depend upon only on the biochemical parameters. So the latest, the very recent generation of contemporary scientists, doctors, they may not know about the Wayne's clinical index at all. But senior persons, of course, senior doctors of the current generation of this contemporary system also, they depend upon Wayne's clinical index, and they plead for the importance of Wayne's clinical index. Anyway, that's the other part. Now, Wayne's clinical index is a simple means of deciding whether a patient is thyroid, hyperthyroid or hypothyroid. And the scores are, this is a standard score which is given based upon the statistical analysis of a large number of population. So if the patient symptom score, and you have the sign score. Symptom score, if the patient has a dyspnea on effort, then the score is, sorry, there is a typing error, it's dyspnea on, it should be effort, not effect. Dyspnea on effort, sorry for that, it's +1. If the patient gives a symptom of palpitations, +2, tiredness, +2, preference for heat, -5, preference for cold, +5, excessive sweating and nervousness, those scores are based upon same. Appetite, weight increase are about the signs. Parvothyroid, blue, and exophthalmos. Exophthalmos is assessed again based upon the three categories: a frank exophthalmos, lid lag, or lid retraction. Lid lag is what you see in these three pictures. The lid lag is where the upper lid is just stretched out, and simply it looks, the eyeballs are not fully protruded, but only the upper eyelid seems to be stretched out as such. Then the lid retraction is, the lid tends to be just the interior portion of the lid is seen. Exophthalmos is where the eyeball is fully protruded. So a full developed exophthalmos would have totally 5 scores, +5 scores. If it's only the lid lag, then it's only +1 score. Lid retraction +2. So exophthalmos, which is generally considered as a standard sign of hyperthyroidism, again, when it comes to the clinical index, you will have the different levels of the scores. And if the patient has hyperkinesis, rapid movements +4, and hot hands moist +1, and so on, pulse rate, the resting pulse rate, that's if it is less than 80 and 90, more than 80 or more than 90, then the scores are 4. If the patient has atrial fibrillation, +4 or minus would also have the minus scores. Now, if you assess a patient's clinical symptom and signs and put the total scores And if the score comes as more than 19, it's a definite case of hyperthyroidism. If it is less than 11, it's hypothyroid. 11 to 19 is unequal, and the diagnostic accuracy of the Wayne's clinical index is about 85%. Now, the diagnostic accuracy of biochemical parameters is just around 80%. That's the point. Wayne's clinical index, assessment of a patient's clinical sign and symptom based upon the clinical index, has a higher accuracy rate, whereas the accuracy rate of a single thyroid function test level, T3, T4 level alone, would have accuracy of only 80%. Rather, it becomes 100% if you have repeated 2 or 3 sittings of T3, T4 level assessment, that becomes 100%. Or a T3, T4 with the free T3, T4 and the thyroid antibodies as well as reverse T3, then it becomes accurate, 100%. So, thyroid function test and a simple, that's a biochemical test which requires all that paraphernalia, maybe the positive mark, compared to a simple clinical test which you can do without any investment, cost investment, but simply time investment. You may need around 5 to 7 minutes to assess these scores and maybe plan that chart. You will be able to make out whether the patient is really hypothyroid or hyperthyroid. And I still continue to use these same exact parameters for clinical assessment to decide whether the patient is hyperthyroid or hypothyroid. That doesn't mean that I don't subject the patient to T3, T4 levels. Those biochemical tests are done essentially. But when it comes to the question of decision making, I will be giving more stress on this clinical index than otherwise. But very interestingly, if you look at the recent editions of the surgical textbooks, you will not have any description of the pain's clinical index. Now, when it comes to the question of hypothyroidism signs, when to treat with only Ayurvedic treatment and when to supplement with the contemporary thyroxine or supplementation treatment, that's the one of the important question. To have that definite answer, of course, it may be, the opinion may change from one physician to the other. But my approach is, if the patient has very obvious signs of hypothyroidism and there is a definite reduced T3, T4 level and the TSH level is raised, that primary hypothyroidism, TSH level is more than 10 and the T3, T4 level is significantly reduced, in that condition I will consider this as primary hypothyroidism, and in such conditions our Ayurvedic treatment alone may not be enough to treat that patient. You will have to supply the patient with thyroxine. Either you may prescribe or refer the patient to a facility where such a prescription is given. Now, there is another set of the patients where the patients may not have full-fledged clinical symptoms of hypothyroidism, whereas the only one or two of those symptoms are manifested. And among those symptoms that are manifested, the most common clinical symptom which we see would be obesity, weight gain. Weight gain as the first and foremost symptom of the thyroxine hormone or hypothyroidism. And it's already established, like the weight gain and the TSH levels, their relationship is almost established, and weight gain in females, particularly in middle age, and TSH level, that could be the early clinical sign of a patient going into an overt hypothyroidism, and that's one opportunity where we can treat the patients, and that's exactly where the Agni-mandya, the abnormality of the Agni, would be producing the Sthaulya. And the description of the Agni, Vishamagni, producing the abnormalities of the Medodhatu, the very important is Medasa Avta Margatpatu Vayu Kosti Visheshva Charan Sandushyati Agnim Aharam Shoshitavi Tasmat Shigram Jarayati Aharam Abhikamshati Vikaramsha Apute Ghoran Kanshit Kalabetikramata Etad Upadravakaraha Visheshan Agni Martha. When the Agni and Martha are combined together, the obvious hypothyroidism signs are seen and they will producing more complications. Multiple symptoms could occur. Among them, the most important is Medo Mamsi Atibruddhatvad Chalaspi Kudarastanaha. The obesity, Sthaulya would be one of the important symptoms. Now, if a patient has the Sthaulya, the obesity as the major issue, and the other clinical symptoms are not very obvious, and the T3 T4 level is just marginal level. At the same time, TSH level may be within 10. In such conditions, I would prefer to still prescribe with the Ayurvedic treatment, manage the patient with Ayurvedic treatment without going into the thyroxine supplement and follow up. And that again, we can have a good number of patients where we can show the results. Of course, very few of the patients may require thyroxine supplement in due course of time, or at least that need of thyroxine supplement can be postponed to a great extent with the treatment. My prescription usually would be Kanchanara, Arogyavardhini, Kumaryasava. Virechana is another game changer. Giving Virechana would be game changer. Of course, in every patient of thyroid disorders, one of the common advice would be to practice pranayama, at least simple pranayamas, which again can produce a significant benefit. Now, I may advise the patient to do the pranayama. How many of the patients will be doing the pranayama? That's another questionable. So I will not go into that kind of a structured study part observation, but this is one of the important issues which can benefit. Now, the other important clinical signs of the hypothyroidism, most of the times you may have a few of the patients where the majority of these symptoms of hypothyroidism would be developed a full-fledged primary hypothyroidism, where other diseases are not known. The patient has a full-fledged hypothyroidism, primary hypothyroidism, where the patient's TSH level is raised and the T3 T4 level is lesser, where thyroxine supplement is needed. Now, whether the thyroxine supplementation is needed or not would be based upon the cause. Now, a few of the causes I will just discuss in the coming slides. I will discuss about some of those conditions where a real thyroxine supplement is needed or not. Now, suppose a patient has a full-fledged thyroid hypothyroidism, and the patient is on thyroxine, but still those symptoms are presented, and the symptoms which we know, the standard symptoms are either there could be a puffy face, the appearance, there could be a impaired sensory, reduced hearing, and of course the thyroid, the goiter, visible swelling, the pulmonary symptoms of pulmonary effusion, shortness of breath, the metabolic symptoms like weight gain, gastrointestinal symptoms like constipation, musculoskeletal symptoms like cramps and fatigue, neurological or psychological symptoms like a patient may have impaired cognitive functions, speech slur, depression, which may look like psychiatric symptoms, and the cardiac symptoms like bradycardia, pericardial effusion, reproductive symptoms, very common irregular or heavy periods or loss of libido, subfertility, etc., or in the extremities paresthesia and so on. So in these conditions, when a patient comes with that obvious clinical signs of hypothyroidism, and thyroxine supplementation is necessary based upon the causes, but the patient still has these symptoms. That's one of the important issues. Majority of the patients, even after supplementation of the thyroxine, these symptoms may not be relieved, and in such conditions, there is a good scope for Ayurvedic treatment as a combined treatment, as a co-prescription of thyroxine. Now, my prescription ranges would be, in all these patients, one of the basic prescription I would be giving as a co-prescription would be Arogyavardhini, Kumaryasava as a Datthatagni Mandahara. And thyroxine necessary if these symptoms are fully developed and the patient has an obvious primary hypothyroidism. And in these conditions, if the patient has very prominent symptoms, in such conditions, I would be adding some co-prescription based upon the symptoms. That's what I say, symptomatic supplementation of Ayurvedic treatment. Patients who have neurological symptoms or psychological symptoms, I would be prescribing Smithsagarosa. If the patient has a cardiac symptoms like bradycardia, etc., my co-prescription would be Prabhakaravati. And if the patient has an abnormality of the reproductive system, my prescription would be Chandraprabha. And if the patient has that paresthesia, brittle nails, etc., Ashwagandharishta is the usual prescription. Ekanga Virarasa is the other prescription in case of sensory pathologies. And Punarnamandura in case of pulmonary effusions or patients who have that pulmonary symptoms as such. And if the patient has weight gain, Kanchanara is the usual prescription. Along with that, as I just referred to in the previous slide, as gastrointestinal symptoms like constipation, avipatikara, Draksharishta, the other issues. Another very common troublesome symptom which the patient would be very much worried is about the brittle hair and the hair fall, for which I don't suggest any specific treatment. But my suggestion is don't use any of the chemical shampoos, simply use coconut oil and simplest soap. That would be the best of the choice in case of hypothyroidism induced these hair fall and hair losses. and rather younger female patients who come to us would always grumble about that hair loss much more seriously than any other physical symptoms as such. Now, then the one point which I just referred to would be in the previous slide is the discussion about whether the patient requires a thyroxine supplement or not based upon the causes. Now, coming to that part, one of the common disease established of the thyroid gland, which requires these thyroxine supplement, would be thyroiditis. Thyroiditis is one of the diseases. Now, whatever we have discussed till now is about hypothyroidism as a clinical presentation. Whether the patient has a primary thyroid disease or not is not the issue. But now I will come to that part where the diseases of the thyroid are discussed. And again, I will be very brief because already I have crossed the time limit, so I think I have to be brief. Thyroiditis is one of the common disease condition which requires a treatment from the clinical point of view, and the thyroiditis could be of three categories mainly: acute, subacute and chronic. And in the chronic, that is autoimmune, Hashimoto's thyroiditis is one of the important issues. Postpartum thyroiditis after the delivery is another of the condition where we have very little to do, and it's a self-limiting disorder. Now, acute infective conditions is where the patient would have the exact clinical symptom of the Vata Jagalaganda. Tadanmitah Krishnasiravanaddha Shavo Arunava Pavanatmagastu Parushyiktah Chiravruddhi Apakah Yadrichaya Pakam Yat Kadachita Vaidasyam Asisijanto Bhavetata Tanugala Prashoshaha. These are the symptoms of acute infective or subacute infective conditions. Acute infective, the incidence is quite rare. Often it presents exactly like any other axis, where the patient would have acute fever and then local swellings, and occasionally it may even result in a pus formation. So, in such conditions, the patient may not have an abnormality of the thyroid functions in the immediate stage, like in the early stage there may not be a abnormal thyroid function conditions. Rarely a few of the patients of acute infective conditions can result in a thyroid storm, that's acute hyperthyroidism can occur, or some of the patients may even have a hypothyroid crisis, very rarely. But majority of the patients, they do not develop that, and it's only like local swellings in the thyroid area, and it would be painful, patient would have fever. And in such conditions, my usual prescription would be Mrutyunjaya, Trifalaguggulu, antibiotics SOS. If there is already a obvious pus formation and the total leukocyte count is quite high, in such conditions antibiotic may be needed. Subacute infective pathology is usually self-limiting, where the patient would have a relatively less painful condition, and the clinical symptoms are mild. The condition becomes chronic, and in that condition, my prescription would be Mrutyunjaya, Trifalaguggulu and Arogyardin in the active phase. And usually it's a viral origin. Patients who have viral infections, subacute infective thyroiditis has been the usual cause as such. After the COVID, now number of that subacute infective thyroiditis patients are increasing. Since the last 2 years, I am seeing much more patients than what I have seen in the whole practice earlier. So there is a quite direct linkage between the viral pathologies and maybe these vaccines after virus and so on, the controversial issue. But anyway, subacute infective thyroiditis is one of the issues which are rather more common now. But most of the times they are self-limiting. The whole course is about 2 to 3 weeks. Then it subsides and there is no need of long treatment. But only the point is you have to identify that at the correct time, and during that period active phase Arogyardin is probably required, but later on there is no need of treatment. Whereas chronic, that Hashimoto's thyroiditis is the next common condition which we see. Reduced thyroiditis is a very rare condition. Hashimoto's thyroiditis, which is the rather maybe, as I told you earlier, some 4 or 5 years back, even the thyroiditis, I used to see more of Hashimoto's thyroiditis than these viral infected thyroiditis or subacute. But since for about 2 years, there are more of viral thyroiditis than really Hashimoto's thyroiditis. So the picture is changing. But importance of Hashimoto's thyroiditis, that's autoimmune thyroiditis, still exists. The typical presentation of a autoimmune thyroiditis would be at the onset, the patient may have mild pain and maybe a local hardness, that feature of hardness over the thyroid gland, local symptoms may be presented, and during that time the patient's T3, T4 levels would be below normal. Then there is a phase of hyperthyroidism phase which continues for about 3 to 4 weeks, or very rarely about 3 months, 2-3 weeks to rarely about 3 months, where the T3, T4 level will be raised and the TSH level become lower. Now during that phase, if you look at the patient, if a patient comes to you, patient may have all the clinical symptoms of hyperthyroidism, and many times the patients are prescribed antithyroid drugs. Of course, if the symptoms are quite high, antithyroid drugs are needed. So I am not saying that the patient should not be prescribed, but if you have diagnosed the condition of autoimmune thyroiditis, it is necessary to monitor how long the patients have the hyperthyroid phase, and once the hyperthyroid phase is over, the antithyroid drugs have to be stopped. Many times the patient may be continued with the prescription unnecessarily, and then there again a problem. Naturally, that patient would go into a hypothyroid phase next for about a few of the weeks to 6 months. Then a patient of hypothyroidism would always have a normal euthyroid level, and recovery would occur unless there are some other acute complications in between. More than 95% of the patient would have a normal thyroxine level. TSH may remain to be raised for a longer duration, so there may be a subclinical hypothyroidism phase in the later stages, and the patient may require a thyroxine supplement during only the hypothyroid phase. In the hyperthyroid phase, an antithyroid drug may be necessary. And of course, from Ayurvedic prescription point of view, I will be treating the patients with the Mrityunjaya, Tripura Amsalista during these phases as such. Hyperthyroid phase, if the hyperthyroidism is quite significant, then antithyroid drugs may be necessary, because hyperthyroid is a very critical issue where there can be cardiac complication, and if the patient has a more palpitation, pulse rate is more than 90, there is no choice. You need to give antithyroid drugs as well as maybe beta blockers. They are necessary because they are life-saving. Critical complications can occur, and hence no hesitation about prescribing those drugs. But the important from the clinical point of view is identifying those patients accurately and phasing out the treatment. If you do not follow that phasing out of the treatment, and the same prescription is continued, either the same prescription of antithyroid drugs or the prescription of thyroxine at this stage given, if it is continued, that would be producing more trouble, and hence whenever we see a patient of Hashimoto's thyroiditis, repeated follow-up and then assessment of the condition is absolutely necessary. And the standard grading of the Hashimoto's thyroiditis would be based upon the observations of TSH and free T3 levels. Up to the stage of 2, the TSH and free T3, T4 levels would be normal. Antibodies, thyroid antibodies may be present or otherwise. Only in the stage 3 and 4, you will have TSH levels raised, and the T3, 4 levels would be either normal or maybe slightly raised as such. And the other conditions may be, there could be stage 4 only, the TSH would be raised and T3, T4 level would be low, and the remission level, everything would be normal. So all that what we have to do is follow, regularly observe, and plan the treatment in such conditions. That's one. Then hypothyroidism in pregnancy is another of the important issue. Now data says that in India, incidence of hypothyroidism in pregnancy is quite high and much more than the global average, and the prescription is done, and it's one of the danger area. I would never intervene in that condition. Pregnancy patients, the need for thyroxine is much more than the average, and the fetus is depending upon the maternal thyroxine till about 37 weeks or even up to the delivery to a great extent. There is up to the stage of delivery, the fetus is dependent upon the mother's thyroxine, and hence supplementation of the thyroxine is necessary. And from my clinical practice point of view, I would never meddle with that. A pregnancy patient with maybe borderline hypothyroidism or maybe subclinical hypothyroidism I will not meddle. The patient would be requiring the thyroxine supplement, and the thyroxine supplement has been done. But postpartum, after the delivery, of course, we can plan the management in the same manner. As I told you, the incidence of primary hypothyroidism in pregnancy is quite high, and in some of the states like eastern states and northern Kashmir and so, the incidence is very high, and our states, Karnataka and Kerala, they are in the moderate incidence status as such. The problem of maternal hypothyroidism is because the fetus is developed depending on the maternal thyroxine, and if there is a slight variation, there could be congenital hypothyroidism, and congenital hypothyroidism is a very critical issue. It can result in a severe condition like a criticism where the whole life could be affected, and hence in such conditions thyroxine supplement would be necessary. I will never try to withdraw or modify whatever is prescribed. That has to be continued after the delivery, then we can manage. So that's about in brief about the hypothyroidism. I'm sure I have not covered the whole topic, but from the clinical practice point of view, among the type of the patients whom I see, I think I have referred to the major component of that part. The next is about the hyperthyroidism. The issue of hyperthyroidism is the clinical symptoms, of course, are very obvious. It's well known, like palpitation, chest pain, psychosis, and so on, which is well known. I'm not going into that part. But the most important issue is that a patient of hyperthyroid has a very high risk of going into cardiac complications in many ways. Like there would be an increased stress upon the heart. The muscles are more sensitive to the catecholamines, and the requirement of the heart pumping would be more, and hence a possibility of arrhythmias, possibility of cardiac acute complications of the heart would be more, and hence every patient of hyperthyroidism has to be carefully handled, and simply managing with the only Ayurvedic treatment often may not be possible. So antithyroid drugs may be needed in every patient of hyperthyroidism. Particularly, my criteria is if the patient has a pulse rate of more than 90, that patient essentially requires antithyroid drugs. So again, the issue is whether I prescribe it or the others prescribe it. That's another point. If the patient is really hyperthyroid and then the patient is on antithyroid drugs, I would not stop that, and that's necessary. With the Ayurvedic treatment alone, it may not be possible. The other choice would be surgical treatment. Now, surgical treatment, in which of the conditions surgery is possible, that's another part. And I would not hesitate to do the surgery also, depending upon the indications. Like a toxic nodule, I would definitely do the surgery, and partial thyroidectomy. Whereas in tumor pathology, I may not do the surgery, I may refer the patient to somebody else. So that's all depending upon the other issues, but surgical treatment may be necessary. A hyperthyroidism condition also may be facilitated, diagnosis may be facilitated by hyperglycemia, hypercalcemia, abnormality of the liver functions, cortisol level may be altered, leukocytosis, hypokalemia also can occur in hyperthyroid conditions. And one of the emergency conditions which can occur in a patient of hyperthyroid condition is a thyroid storm, one of the high risk conditions. A patient of hyperthyroid condition may develop these thyroid storm due to any causes, like a patient who has a sepsis, a patient of hyperthyroidism undergoing surgery of any sort. Induction of anesthesia in a patient with hyperthyroidism has a potential risk of going into hyperthyroidism or thyroid storm as such. So, any sort of surgery, whether it is a surgery of thyroid gland or otherwise, a patient of hyperthyroidism is a risk for both surgeons as well as anesthetists. So, when we do the surgery for any other condition, if the patient is a hyperthyroid, I will be always more careful and deciding like whether the surgery is really needed or not. So that part of assessment is totally different issue. I think we will not discuss that part in the today's presentation. But it's a issue. If you are not careful, patient may develop a thyroid storm in the post-operative period. A person who consumes excess of thyroid hormones, overdosage, or withdrawal of antithyroid drugs suddenly without specific reason, a diabetic ketoacidosis, direct trauma to the thyroid gland, and one of the important issues, vigorous palpation of an enlarged thyroid, a patient coming to the goiter, And coming to educational institutions, all the medical students palpating the thyroid gland, that can be a cause for the thyroid storm. Not that everywhere you have to restrict, but in a teaching institution, this also is one of the issue which you have to keep in mind. And the patient may develop a thyroid storm, which is a acute medical emergency, and fatal complications are very high. The symptoms could be like starting with the fever, profuse sweating, and patient may have weight loss, respiratory distress, fatigue, nausea, diarrhea, jaundice may occur, or even seizures and coma can occur. So management of thyroid storm is a medical emergency which requires the supplementary therapy, life supporting treatment. I will not go into the details, but it's beyond the scope of managing with the only ayurvedic remedies, because you may need any of those alternate sources of the remedy, and that's how it has been treated. Now, these are exactly what's mentioned as a Vishamagni functions in Madhavnidana. Vishamuham Parthajan Bogan, Tishnan Pitanila, and Karoti Agni Tata Mandaha. The Mandagni is about the hypothyroidism Lakshana symptoms, whereas the Vishamagni would produce Matra, Atimatra, Peshila, Sukumya, Silvati, Dikshna, Hititam, Vidyata, Samagni is always better. Now, hyperthyroidism causes, again, I will be very brief because already I have crossed the limits of time. The commonest would be the Graves' disease, which may require a surgical treatment, and with the Ayurvedic treatment alone, an established Graves' disease cannot be managed. But antithyroid drugs may be necessary, or surgery also would be necessary. Toxic multinodular goiter, where again you may see the multinodules. Adenomas, patients without active thyroid disease may have mildly positive thyroid antibodies, and this also is a patient where the patient may have hyperthyroidism conditions. Subic thyroiditis, as I told you, or the Hashimoto's thyroiditis in the initial stage, in the early stages. Hyperthyroid conditions can occur, but those hyperthyroid conditions may not require a prolonged treatment. So, a patient of hyperthyroid condition has to be assessed and decided like which of the conditions require surgery or not. Now, from Ayurvedic point of view, you have another opportunity. Patients who are on antithyroid drugs, particularly methimazole or the thiazide, they develop the complications. The adverse effects are more common. Now, among the adverse effects which are commonly seen, polyarthritis, pain in the joints, or vasculitis symptoms are one of the common conditions. Though, as per the standard pharmacological textbook data, polyarthritis symptoms occur in only 1 to 2%. But what I have seen is this would be much higher. It's around 10 to 15% of the patients who are on methimazole for a long duration, they develop these symptoms of pain, arthralgia there. And this antithyroid arthritis syndrome is an established entity. And patients who are on antithyroid drugs, like as in Graves' disease, they tend to develop these complications which mimics the rheumatoid pathology, but not the real rheumatoid pathology. There will be painful edema around the joint would be swollen, and gradually there could be slight deformity and hyperemic changes at the joint area. These are the typical signs of antithyroid arthritis syndrome, and there again you have a scope for Ayurvedic treatment. And my prescription there is considering this as Amavata produced through the drug, my prescription would be Kaishara and Dashamula Niruhavasti, and where we can produce a significant change in the clinical picture. The contemporary prescription of analgesics and the anti-inflammatory drugs may not give the same equivalent results as that of Kaishara and where we have an upper age. So though, as I said about the antithyroid drugs and need for antithyroid drugs in thyrotoxicosis, the scope of Ayurvedic treatment is not much, whereas in the conditions of antithyroid arthritis syndrome produced as a complication of antithyroid drugs, we have a better scope. Then the last part is about the goiter. Goiter, by definition, is a swelling of the thyroid gland. Again, I will not go into much of the details about this. And it's often identified as a swelling in the neck discovered by the patient, or a patient may come with the imaging study reports where these imaging studies were done for some or other reason, or the patient may come with the symptoms of the compression, local compression like dysphagia, dyspnea, etc. due to the swelling. Pain due to hemorrhage, inflammation and necrosis could be the other condition, and the patient may have signs of hyper or hypothyroidism in a case of goiter. Thyroid cancer with or without metastasis also could be a presentation as such. As far as the causes of the goiter, well known, the congenital causes like thyroglossal conditions, about the acquired conditions, thyroiditis, subacute or acute or chronic, any of them may present with goiter. But from the clinical point of view, the most important are the goitrogens, where the iodine deficiency may have occurred either due to the substances which reduce the absorption of the iodine or real iodine deficiency which can produce the goiter. These are the important conditions, but very important is incidence of the real iodine deficiency goiter now is much lesser after there is a legal issue. The iodized salt only has to be sold. Prevention of that illegal inhibition or prohibition against selling of the non-iodized salt in the market in 2017, I think, no, 2017 or 16, that law was enabled. But of course, that law is now questioned in the High Court, so there is a legal issue, confusing issue. I will not go into that part. But after that, the incidence of the iodine deficiency goiter has been reduced to market. Colloid goiter has become more common, whereas goitrogens like lithium, patients are on psychotic drugs. Lithium is an antipsychotic drug. They tend to develop goiter quite frequently, and the diseases of the thyroid gland, cysts of the thyroid gland may present as the goiter, and thyroid nodules can also be caused. The important is every patient with a goiter has to be examined thoroughly, and I would always prefer to have a FNAC, fine needle aspiration cytology, to confirm about the possibility of a tumor. The one of the worst possibility in case of a thyroid swelling is a thyroid malignancy, tumors, the thyroid carcinoma is very difficult to make out clinically. Unlike that of the other carcinoma tumors, which would be having a firm consistency and adherence, the thyroid carcinoma may not have that kind of adherence. It may look soft, it may look innocuous, it may look like virtually any other colloid goiter. So, as a rule, every patient of a thyroid nodule, a solitary or enlarged goiter, I would be preferring a FNAC along with all the clinical workout and decide like whether the patient requires surgery or not. And ultimately, the most dependable treatment in a goiter is a surgery if necessary. Some of the conditions can be like a simple colloid goiter. There may not be need for surgery, and in such conditions, I may prescribe Kanchanara Gulgulu for a long time, though it may not produce a regression, it may just reduce the possibility of the growth. And all these such goiters, I will be diagnosing them as obviously Galaganda. The description of the Galaganda in Sushil Samhita is of a bilateral enlarged goiter, where it is compared to Mushkavat Lambategare, Nibaddha Shveturyasya, Mushkavat Lambategare, Mahamma Yadiva Hriswaha, Galagandam Tamaksheta. Mushkavat, that bilobular swelling is described as such, so the description is same. And the most important is the incidence of iodine deficiency goiter has remarkably reduced from 1971 to 2013. This is data from India, and it has become remarkably reduced. And as I have seen also, in 80s when we were studying, and particularly in Banaras when we were studying, we had seen more iodine deficiency goiters, whereas number of iodine deficiency goiters are markedly reduced. If you see change in the total incidence of iodine deficiency goiter now is seen, and management of other goiters is based upon that. I will not go into more details about that planning of the management issue because the time is up. And the last point is thyroid treatment market is one of the very remunerative market, and it is growing very rapidly, and the increment growth rate is quite high as such. Annualized growth rate is more than 3.0%, and globally it's one of the major attractions. So those Ayurvedic formulations about prescriptions about thyroid gland, etc., have a wide scope for the future as such. With this, let me conclude, and the take-home points are: Samhita literature has minimum details of thyroid physiology. Ayurvedic prescription perception of thyroid disease is based upon clinical correlation rather than the textual description, except in the Galaganda. Judicious assessment and careful assessment gives a good scope for Ayurvedic practice. With this, let me conclude. Thank you for the patient hearing, and I would expect any of the feedbacks either to my mail ID or maybe WhatsApp. If this let me end, and if there are any questions, I think I will be trying to answer the questions. Of course, there are some questions, I think.
Yes, sir.
Lots of questions are there.
Yes, sir. Yes, sir. Thank you, sir. Before we go for the questions answer, shall we go for a short break for a product presentation so that
Okay,
you
fine. No problem.
so that you can also rest. And I request our audience to post their questions in the Q&A session. After the product presentation, definitely we'll be taking up the questions. Dr. Rahul Panen for the product presentation. Thank you, sir, for your wonderful presentation. We'll be coming back, sir.
Thank you, sir, for the excellent presentation. And I'm entering to a small product presentation from Siddharam Ayurveda. As we all know, Siddharam Ayurveda conducting Acharya Sanam as a part of our 100th year celebrations. Siddharam Ayurveda, 100 years of healing legacy. I would like to start with a few of the special classical products from Siddharam Ayurveda. Here you can see the Brihat Katphaladi Kashayam, that is from the Vaishyaji Ratnavali. It is a very special yoga which is indicated for the Galaganda, Gandamala, Swarabheda, and Galamaya, and also has a very good action in Sanipada Jwara, Karna Shula, and also almost all the Shilo yoga. Brihat Katphaladi Kashayam from Siddharam Ayurveda. And the next one is Varadi Kashayam. It is also a rare formulation from the Ashtanga Hridayam. The major ingredients are Asana and Chitraga and also Loha Patra with Nisha. And it is indicated for the obesity and also for the metabolic disorders. And we are manufacturing it in two forms, Varadi Kashayam and also Varadi Kashayam tablets. And the next one is Doshivishari Guliga. It is also a rare formulation from Ashtanga Hridayam Uttarasthanam.